Okay, sir.
I'll start.
Good evening, one and all. And first of all, a happy Doctor's Day to all of our speakers, panelists, and our dear members. And this day not only make us proud as a doctor, but also put us a responsibility of updating ourselves to stand before the disease, to help the mankind to come out of the disease. And as we are stepping into our 26th edition of this peculiar case series in renal transplant, and this day is no better than any other day, because we have completed the 25th and getting into the 26th episode. And today is a Doctor's Day, and it has been the wonderful day for this program. And adding to the charm of this day, we have two wonderful, we're going to hear two unique and rare presentations, which perhaps first of its kind in India, is by Dr. Sachin Soni regarding the HIV transplant, ABO incompatible transplant among the HIV positive donor and a recipient. And we could be able to hear from him the experiences and difficulties he has faced. Second, we are going to hear about a case regarding the renal involvement in a bone marrow transplant recipient. So first of all, we are very much happy and inviting our panelist, Dr. Srijit, and from JIPMER. He is a professor of nephrology from JIPMER, Pondicherry. Not only he holds this position, he's also a member secretary of cadaver transplant program of JIPMER, and also he's head of NOTO of Pondicherry chapter. And his silent and ferocious reading and passion towards nephrology has made him to start the Department of Nephrology in JIPMER Pondicherry way back in 2010, and it has made him to a level of one of the best institute of nephrology in India. And a man of few words, and he can his silent and perseverance to nephrology is somewhat exceptional, and is not new to this forum. He is always with us, helping us to have good meetings here on. Joining him is Dr. Raja Ramachandran. He's associate professor of PGI Chandigarh, and he's not new to this forum, because not to this forum, and also for international and national forums, and he has been in all the majority of the forums giving the talks. And he has special audience for his talks, actually, for his clarity, for his silence, for his slow and clarity of thoughts. And we are very much sure that both of you will give your inputs for these two cases and make this meeting a wonderful and academic one. And to introduce our speakers, one under the guidance of Dr. Sampath sir, who is not also new to this forum, and one word can explain him: his perseverance, passion towards learning and practicing and teaching nephrology is always boon to us. And many congratulations and best wishes for you on your birthday. So today is Sampath sir's birthday. It's happened to be Sampath sir's birthday, special day for him also. Yes. And his postgraduate, Dr. Belinda, is going to present the first presentation of organ marrow kidney cross-track. And second speaker is Dr. Sachin Soni. He's an interventional nephrologist from Medicover Hospital, Chhatrapati Samrajnagar, Aurangabad. And he has a lot of accolades on his name. He's been a visiting fellow at the University of California, San Diego Medical Center in March. And he's also worked with Claudio Ranco at St. Bartolo Hospital in Sella as an international nephrology fellow. And he has 41 PubMed indexed publication on his credit. And he has 2 textbook chapters. All in all, is a good academic performer. And we are going to hear from your rarest of rare cases to be presented. Without wasting much of the time, I call upon Dr. Belinda to start his first presentation, a bone marrow kidney cross-track.
Thank you, sir. Good evening, all. I'm audible, right?
Yeah.
Okay. Good evening, all. So I'll be presenting a rare case of renal graft versus host disease in an allogenic bone marrow transplant patient. So this is the story of the patient. He's a 40-year-old male who underwent bone marrow transplant for aplastic anemia 1 year ago. So he has been given a conditioning regimen with fludarabine and cyclophosphamide that time. 1 month within the bone marrow transplant, he had developed a gut acute GVHD, which was biopsy proven, and he was treated with steroid as well as tacrolimus for the same. However, 2 months prior to this presentation, that is by the month of February this year, tacrolimus was stopped considering a CNI toxicity. The story continued. He also had steroid-induced hyperglycemia, and he had developed a new onset hypertension 2 months back, that is late of February. Now he has been referred to the nephrologist in view of worsening renal parameters. So this is his creatinine profile. January, he had a baseline of 1.1, which was steadily increasing. February, it had reached 1.4, and by April, it was 2.7. So on examination in our OPD, he was pale. His vitals were stable at that time. He was taking his antihypertensives. He was afebrile, as well as he had normal systemic examination. These are the baseline investigations. He had a borderline HB 9.4, platelets 1.57 lakh, creat of 2.7 at that time, and urine protein 1+ with few RBCs in the urine. Other investigations, LDH is high, 445. Peripheral smear showed 2% cystocytes and mildly reduced platelets. CMV, adenovirus, BK virus PCR showed not detected. So at this juncture, we thought what could be the cause of renal failure in this patient. It could be either an acute cause or chronic cause. Acute causes could be from nephrotoxic drugs, infections like CMV, adenovirus, Epstein-Barr virus, etc. Thrombotic microangiopathies, acute graft versus host disease of the kidney, tumor lysis syndrome, or a veno-occlusive disease. Chronic causes could be a chronic GVHD as a sequelae of acute kidney injury, or again drugs. So putting all together the clinical as well as lab parameters, a new onset hypertension in this patient, two months, that is by February, patient being pale, and lab parameters showing anemia, thrombocytopenia, high LDH, 2% cystocytes, proteinuria, and renal failure. We thought the diagnosis could be a thrombotic microangiopathy. Further, to prove the diagnosis, we went ahead with a renal biopsy and electron microscopic study. And the renal biopsy showed mild mesangial matrix accentuation with segmental mesangiolisis, enlarged endothelial cells, duplication of capillary walls. All the immunofluorescence stains were negative except for C4T positivity in the glomerular capillaries. So thus made a diagnosis of chronic thrombotic microangiopathy, probably secondary to graft versus host disease. So this is the histopathology showing mesangiolisis. The capillaries are filled in with fragmented RBCs. So this is another stain showing double contouring. The arrow marks are showing the double contour. And this is the C4T positivity, which is strongly positive, lining the glomerular capillary membrane. This is the electron microscopic picture showing thickened basement membrane and widening of the subendothelial space. So what is graft versus host disease? It is the donor T cells which recognize the recipient cell as foreign and initiate an immune reaction. So when we say GVHD, the common organs involved are skin, liver, GIT, lung, as well as the hematopoietic system itself. However, renal GVHD is a rare entity, and the literature search showed 1% incidence. Graft versus host disease in biopsy can be seen as different presentations. Either it can ensure the podocyte presenting as a minimal change disease, or a FSGS, or a tubular injury causing acute interstitial nephritis, or an endothelial injury causing a thrombotic microangiopathy like picture, or an immune complex mediated injury presenting like a membranous nephropathy. So what is the connection between renal GVHD and TMA? So in GVHD, the donor cells target the vascular endothelial cells, causing its damage, thereby promoting thrombus formation as well as fibrin deposition in the capillaries as well as arterioles, causing a thrombotic microangiopathic picture, a microangiopathic hemolytic anemia along with consumptive coagulopathy, and finally leading to renal failure. Coming to the diagnosis part, there are no diagnostic criteria defined for renal GVHD, unlike in other organs. It is suspected when there is a classical target organ involvement, say a skin involvement or liver involvement or a GI involvement, or other causes of renal injury. When it is ruled out, we can suspect renal GVHD in a patient. Coming to other inflammatory markers, there is one new marker which is called elafin, which is a low molecular weight molecule, which is produced by epithelial cells and macrophages in response to a tissue inflammation. So this has been proven as a marker for skin acute GVHD. However, Hingorani et al. Had used this marker in renal GVHD also. And however, biopsy is the confirmatory test for both acute as well as chronic GVHD. Coming to the treatment part, again, there are no specific treatment protocol defined for this renal GVHD. GVHD part, we can treat with either corticosteroids, calcineurin inhibitors, mTOR inhibitors. Supportive therapy we can give with antihypertensives. We can minimize the transfusions as like in other TMAs and use erythropoietins. In high-risk thrombotic microangiopathy, however, we can consider plasma exchanges and rituximab. However, literature didn't show any evidences for all these things. Eculizumab complement membranous attack complex inhibitor could be playing a definitive role for this. However, it is too costly and it is not easily available in India. Now, coming to the prognosis part, if a GVHD develops in association with the TMA, according to Cho et al., the survival is very poor. So these are the literature search which are in support of this diagnosis. This is a study by May et al. It is from Tokyo, Japan. So here he has discussed about 4 cases which all had thrombotic microangiopathy as the renal manifestation in biopsy. However, 2 cases turned out to be a CNI toxicity induced TMA, and 2 patients were GVHD associated. And this is another study by Motoyoshi. It's again from Tokyo. He also had he had given a case study of a 10-year-old boy who had high-risk AML, who had undergone BMT, later on developing a renal GVHD. And this is another study. This is from Florida. And all the studies, recent studies are showing a high incidence of TMA as well as kidney GVHD in the renal biopsies. So the take-home points: thrombotic microangiopathy in kidney can be a manifestation of renal GVHD. The risk of TMA is very high in a patient who had already had a history of GVHD or currently having a GVHD. And renal biopsy is definitely necessary to find out the exact etiology of thrombotic microangiopathy. Another take-home point is when we suspect renal thrombotic microangiopathy, the immediate step is we would think of a CNI toxicity and immediately stop on the immunosuppressants. However, there could be GVHD causing a renal thrombotic microangiopathy, in which case we have to increase the suppressive therapy. So the treatment is completely different for both the causes, and that's why renal biopsy has a definite role. Thank you.
See, this is can I talk? Am I audible?
Yes, sir. Yes, sir. Yes, sir. Go ahead, sir.
Okay.
Belinda,
Yeah,
please
so-
stop sharing your screen, please. Go ahead,
So
sir.
this was a patient who was referred from our hematology unit with renal dysfunction, and our initial thoughts were in tune with the thrombotic microangiopathy. We went ahead with the biopsy. Biopsy also had the light microscopy showed features, but we were not very definite whether it is thrombotic microangiopathy or something else. Then I was going through the pathology, histopathology books, and found that C4D positivity could be a good marker of a chronic TMA. Then I asked the pathologist to do the C4D staining in this patient. Generally, we don't do it for glomerular diseases. So this is a patient who taught us that C4D positivity in the glomerular is a good sign of thrombotic microangiopathy, especially chronic thrombotic microangiopathy. So this is one of the educative things that I thought we should share with you. Always we have been thinking about C4D, connecting C4D positivity in transplant scenario, but in glomerular disease, you have this in the absence of electron microscopy. This could be another factor which will give impetus to your suspicion of thrombotic microangiopathy. So this was number one. The second aspect was there was a doubt whether it was all CNI driven, but the hematologist had stopped the CNI and then still it was going on. So it is very likely that it is a chronic GVHD. The patient was not willing to undergo dialysis, and he was not also willing to undergo other therapies. Rituximab was also discussed, but he was not willing. Right now, he is not doing well. His creatinine is rising. He is now reached anywhere between 6 or 7 milligrams. He is still hospitalized. So these are the points that I thought I should highlight in this unusual case. Yes.
Thank you, Sandra sir, for
Yeah.
explaining the cases further. As usual, it is a rare case, and as far as mine is concerned, it's rare. So, on the one point we could make out is C4D positivity could be the manifestation of the chronic graft versus host disease. So, bone marrow transplant TMA can be a multitude of causes. So, whether C4, C3, C4 complements were measured for this patient, sir?
Yeah. It was all normal.
It was all normal.
Yeah.
Okay. So I will open to the panelists for further discussion. Dr. Trichy sir, your opinion regarding this?
Yeah, a very interesting case. In fact, very rare, I believe. We are yet to see a patient with GVHD, even though there is an active bone marrow transplant program. The other thought which came to my mind was, it may be it's very infrequent renal TMA in GVHD. Whether doing a complement workup will be C3, C4 is normal, but like we do in TMA, I am not sure about the literature on this. I'm wondering whether it will be useful because sir has reviewed the literature. The other thought which came to my mind, which is not feasible for us, whether using eculizumab will be an option when it is available abroad, because it's again a TMA, seems to be complement activation seems to be there. What are your thoughts on this, sir? Like, will it be?
Yeah, definitely. If eculizumab was was attainable, definitely we could have used it in this patient. See, we have seen that seemingly impossible situations, eculizumab has helped, and a dramatic recovery has happened.
Rajan, your opinion?
Yes,
Yeah.
Raja?
Thank you for the interesting case, sir. So, whenever a nephrologist says interesting, it means nephrologist or a pathologist says interesting, it means the prognosis is not very good.
Yeah.
So I actually see this as a complement mediated TMA. Yes, obviously, the complement mediated, it may be that 20% of the population is carrying, genetic predisposition, only few develop because how they respond to the predisposing factor. Probably the GVHD was actually the predisposing factor or precipitating factor for developing or activating the complement in this case. So yes, people have worked up and shown also that patients with GVHD do have alternative pathway of complement cascade activation, and eculizumab, they saw that there is a survival benefit of using eculizumab. Obviously, in India at this point of time, at least, there is a very restrictive use of eculizumab. But I think with emerging anti-complement therapies, I think we will be able to better manage. And this patient probably deserves an anti-complement therapy. So if I'm not mistaken, there's a trial going on. It's called Apple-Hus study. So where they're giving complement B inhibitors, which I'm also a part of. So there maybe if these kind of patients can get enrolled.
This iptacopan or
iptacopan. And it's a single arm study. It's a single arm study, so you can be assured that your patient will get therapy. So,
but their inclusion criteria that C3 level should be lower.
No,
this patient.
That's not there. What I would, Dr. Srijit spoke about the complement workup. See, there is only one thing that we will have to learn that during the complement workup is to do C5b9. So this is a soluble MAC. So this is the only thing which goes on to show that the complement is activated, because there is a battery of, you have a 20 tests which can be done in patients with complement mediated. But I think soluble 5b9 is the one thing which would be very critical in children. And obviously it's anti-CFH and other things, but soluble 5b9 is something that we should be looking at in these kind of.
Is it available, Raja, inside India?
It's not available, sir. It's done only on the research setting. We do it only on the research setting only, sir. But I think in future, if labs come up, I think this is one test which should inculcate in practice.
Yeah. That's the points of Dr. Rajan. Let me add some points on the TME post BMT. Actually, it's not that much very uncommon. Literature states around 5 to 50% of the bone marrow transplant, especially after whole body radiation, total body radiation transplants are more prone for this kind of GVHD and TMEs. And the mortality rate is close to around 60%. I have seen through that. The one interesting thing they pointed out that, as Dr. Raja and as Dr. Srijit had told, it is disorder of the complement pathway is one of the baseline factors in these patients, and your GVHD and total body radiations, necrolemus will be the predisposing factors for developing chronic TMA. And another interestingly, they pointed that one of the articles which I came across, it is there is no much effect of plasma exchange in these patients of TMA associated with GVHD and all. And what they told is, what they have done is they have reduced the dose of tacrolimus and a combination of tacrolimus and everolimus for preventing GVHD, and to add a basiliximab to stop tacrolimus and add the basiliximab to give a CNA naive situation. Most of the TMA with the bone marrow transplants are associated. They are more focusing on the CNAs and all. And luckily, eculizumab, once we have a complement-mediated pathway problem, eculizumab has a good effect. Rituximab can also be tried. And defibrotide, that is used for veno-occlusive disease of liver, has also been proven to be useful for this TMA associated with bone marrow transplants. And it's a very rare case. And I have seen some questions that so what are the how to differentiate with the TMA of this and the CNI induced TMA is one question we have asked from someone from chat box. How to differentiate this from?
I don't think I'm able to tell you that there is a differentiating factor between the TMA due to drugs and TMA due to the GVHD. See, I think only it's a trial.
Plasmapheresis tried in this patient, sir. Has plasma?
No, plasmapheresis was not tried. So he was not willing for that.
Okay.
Can I add? So, you have withdrawn the CNI. So any TMA which is associated with CNIs, usually, it's a manifestation of acute kidney injury. Most of the acute kidney injury due to CNIs, they reverse after stopping the medication. In this patient, it did not happen. So it's probably, in retrospect, I think you can make a diagnosis of non-CNI related TMA, because that's something that we can be very clear about. And I think I would see it that way.
Nice. Another question from chat box. We can show donor T lymphocyte DNA in the kidney biopsy. The only way to confirm GVHD is we can show donor T lymphocyte DNA in kidney biopsy. Whether it can be done, sir? Any ideas?
I could tell me.
One question from Dr. Pani. He has asked that he has revealed that whether donor T lymphocyte DNA in kidney biopsy is one of the marker of GVHD.
C1q,
T lymphocyte DNA.
T lymphocytes, DNA. Okay.
So it's more of a academic question rather than a practical question, because GVHD, obviously you're expecting the donor lymphocytes to be present in the tissue. And if there is any way we can look for the donor gene material in the kidney, that would probably confirm or refute a diagnosis of GVHD.
Indeed.
Yeah,
Indeed.
you may have to do something like a in situ hybridization or fish
Correct,
technique.
correct, sir. Exactly.
Yeah.
Yeah. I mean, just more of an academic question, I guess.
Yeah.
That's a foolproof method to show that, you know, donor T cells is actually causing the pathology. That's probably the best way to show.
Yeah.
But I think there are two aspects to it. One is whether this is GVHD. So that is one aspect. A second part is whether the TMA you are seeing in the kidney is part of GVHD or not. So I would think it is not essential that T lymphocytes maybe, because it can very well be from an endothelial injury, from antibody mediated injury with complement activation and all. And it may not be, I'm guessing here that T lymphocytes of the donor may not be demonstrable in the kidney, but that demonstrating it anywhere, for example, I believe in GVHD you usually get GI toxicity and all, and during B cells also. So I'm not sure. So, but in this case, there are two things. One is a diagnosis of GVHD, which may not be connected to the kidney. And second thing is whether the kidney injury which is happening and demonstrated to be from TMI is from that GVHD. So there are two. I would look at it as two slightly different issues.
More than that, I was really excited to have this type of C4D positivity in the glomerulus. See, generally, the light microscopy diagnosis of chronic TMA could be sometimes debatable. There could be some pathologists will say there is double contouring, and some will say it is not there. So there is some debate in the light microscopic diagnosis. So if C4D is very strongly positive, that adds. So this was, I think, a real education from this patient, I thought. What about your experience, Dr. Raja and Srijit? Have you done C4D in these TMA cases and found positivity?
To be honest with you, sir, most of the TMAs don't really undergo biopsy, like the HUS kind of entities, they don't. It's
okay.
More,
so possibly chronic TMA, you can just have your pathologist to look into this.
Yes, sir. And my question was, I raised my hand. What was I just missed, where was in the immunofluorescence, where was the C4D present?
No,
electron microscopy, where were the deposits? So that's another question.
No, it was all in the glomerular capillaries. So it was
granular or
granular, and the subendothelial deposits are there.
Subendothelial deposits.
Yeah.
Okay. So probably one question is, did we do an unmasking for IgGs or something?
No. We have not done.
Because sometimes it could be possible that there could be an infection which may actually be
infection.
Although it's difficult, most of the time C4D remains and IgG all goes off. So I'm just thinking aloud, not telling you missed anything.
This patient had any other symptoms of GVHD, like GI symptoms?
No, he had earlier, that 8 months ago, he had a typical gastrointestinal GVHD, from which he had come up after the tacrolimus therapy, and then he has developed this.
And he also had kidney dysfunction at that time or not, sir?
No, at that time he did not. So partially treated, possibly partially treated, and it was a smoldering disease, which has got a manifestation on the renal system now.
Yes, sir. Sir, one thing that I would add is, C5b9 is probably difficult at this point of time. At least if you do a genetic testing and you get a candidate genes like, CFH or something like that, we can be sure, because CFHR one duplication is very common in India. But if you get a CFH which is associated, or CFI or something like that, factor B3,
Yeah,
C
additional factor.
yes, we can be reasonably sure about the complement part. Thanks.
Thank you.
What I was trying to say was that no, because of the GVHD, we had a patient who had undergone kidney transplant with mother as the donor, and she lost the graft also after many years and was on dialysis. She presented with some skin lesions, which turned out to be GVHD. So we don't know the renal histology. She was already on background dialysis. This GVHD per se seems to be very rare in kidney transplant, that too with mother as the donor. But then she had, because the skin manifestation is supposed to be very common along with the GA manifestation in these patients. She had biopsy proven GVHD in the nape of the neck, and she had lesions. That's supposed to be, I think,
Yeah.
in kidney transplant recipients, not bone marrow.
Dr. Srijit, what do you mean by GVHD skin? What are the lesions like histologically? The learning experience, I don't know, honestly.
GVHD, what I understand, you're telling the manifestation. Usual manifestations are supposed to be hematological and
Histology on the skin biopsy you told, right? So that
histology on the skin biopsy.
Yeah.
I don't remember exactly.
Like some leukocytoclastic vasculitis, or is it like TMA in the skin? So
no, it was not TMA. It was not TMA. It was that diagnosis. This happened maybe around 3 years, 4 years back. I didn't know this was a case of GVHD, so otherwise I would have checked it. So I don't remember exactly what the skin lesion. I remember how the skin lesion looked like, but what exactly it was there under biopsy, I don't know. The dermatology people had seen the patient, and biopsy was done by them. And we had a discussion because it was not expected for the patient to have GVHD, but finally it was the final diagnosis was indeed GVHD, not in the skin. Unfortunately,
So another point for the postgraduates who are listening in is one type of hematological GVHD like presentation is when you are doing a patient with O group donor from to a B group or a group recipient. So in these situations, the O group graft can have presentation of hemolytic anemia, from where the lymphocytes can act and then produce a hemolytic anemia like picture. And this is an important thing which where you can have positive Coombs test, and we have had a few situations like that. So it's a part of a graft versus host disease, mainly having a hematological manifestation, but usually it's a self-limited disease, and we have had a few cases like that.
Thank you, sir, for your valuable. If there are no further questions, any other questions to be asked, dear panelists?
I don't have any more questions.
Okay.
Very
I
nice.
answered a question from the chat box also. That was a wonderful case, and learning points, few learning points we have got from that cases also. So thank you, Dr. Sambasar. Thank you, Dr. Belinda. And let me invite Dr. Sachin Soni to have your presentation, please.
Good evening, everyone. First of all, thank you to the forum for this kind opportunity. Actually, listening to all these discussions, I have few confessions to make that I feel very inadequate when I get to listen to all these molecular things, because I'm not good at it. And the forum peculiar, that WhatsApp group itself is contributing a lot to the practical knowledge which we are getting. So thank you for running the group and keeping that knowledge running and getting it spread to all the people. Third, I'm not good in immunology, including transplant immunology. Probably that is a blessing in disguise, because of which I keep doing these adventurous cases. So I'm presenting you HIV positive donor to HIV positive recipient, ABO incompatible kidney transplant, probably first in the world in this combination. So my patient is a 46-year male, diagnosed retroviral disease in 2008. On antiretroviral therapy, presented to me in 2019 with small kidneys. Clinical diagnosis was chronic tubulointerstitial nephritis, etiology unknown. Was started on CAPD with 3 exchanges, and he was fairly well maintained. Recently, he was complaining of anorexia and weight loss. He was repeatedly coming to us with this symptom, and he was getting slightly malnourished with this. So option of kidney transplant was discussed, and before that we did basic investigation to exclude any opportunistic infections which he has, which may be responsible for his persistent anorexia. And when none was found, this was discussed. So wife came forward as a voluntary donor, and there was no other donor in the family. But the issue with this donor was she herself was retroviral disease patient. She was on ART. All her basic evaluation, which we do for transplant patients otherwise, was normal. However, she was B positive and patient was A positive. So it was ABO incompatible, proposed ABO incompatible transplant. And because of the nature of the illness, both the donors and recipient had, obviously swap was out of question. So this was the only possible option in this particular patient to go for ABO incompatible transplant. So this is in brief about the patient. Both were on ART. Viral load for both of them was not detectable. Absolute CD4 count for patient was more than 500. For donor, it was more than 700. Kidney biopsy was done for the donor, and it was absolutely normal. Luckily for us, anti-B titer IG baseline itself was 1:32. It was a 6/6 HLA mismatch. So apart from being ABO incompatible, it was also an HLA incompatible kidney transplant. We did DSA flow cross match as well as CDC cross match. Everything was negative. So before I proceed, we went through the literature to look for selection criteria for potential HIV positive kidney transplant recipients, and our patient seems to have met all the criteria. Effective HIV suppression for more than 6 months with undetected plasma HIV1 RNA, which this patient had. CD4 cell count more than he had more than 500. No active opportunistic infection, and there was no history of other conditions which may preclude kidney transplantation, like progressive multifocal leukoencephalopathy or lymphoma or invasive fungal infections, anything like that. And there was no concomitant infection with co-infection with hepatitis B or C. And this comes from these guidelines are from KDIGO work group. And with respect to living HIV donor, this is HOPE Act, which is HIV Organ Policy Equity Act. And it mentions again, error load not detectable. CD4 count should be more than 500 to be a potential living donor. There shouldn't be a history of invasive opportunistic infection, and kidney biopsy should be normal. So on these counts also, our donor was fit. Her CD4 count was more than 700 with undetectable viral DNA, and all other evaluation was normal. Her age was about 40 to 43. She was otherwise a fit donor. So yeah, so our patient donor met all these criteria. So basically, this was a HIV positive donor to HIV positive recipient, HLA incompatible, ABO incompatible. Obviously, when you look to transplant retroviral disease patient, let me tell you that this was my first exposure of doing HIV positive kidney transplant. So you have to look at all three aspects. Like you have to look at antiretroviral therapy, because some of these drugs have interaction with CNIs. So they may need to be stopped, or their dose need to be modified, and we have to be careful about use of CNIs. Then patient, as the disease itself tells that it is acquired immunodeficiency syndrome. So and you are further immunosuppressing them, and more so in this particular patient because this is HLA incompatible and ABO incompatible. So that is the most tricky issue, and infection risk goes hand in hand. So we know this is a double-edged sword. So if you over immunosuppress, risk of infection will be high, and if you fail to immunosuppress appropriately, risk of rejection will be high. So that is the basic issue in this particular patient. So before we go further, I don't want to go into too much details of these agents, and I don't practice HIV medicine on my own. I take help of specialists, so to say. So these are the 4 major classes of agents. One is NRTI, NNRTI, protease inhibitors, and integrase inhibitors. Other 2 are not much in use. And in general, the prescription for retroviral disease patient include 2 NRTIs plus 1 protease inhibitors. And this is the most common prescription which is delivered out of antiretroviral therapy centers, government and antiretroviral therapy centers. But the issue for transplant patient is protease inhibitors. Like protease inhibitors are rapid inducers of CNIs, so they need to be stopped. Our patient, luckily, already was on 2 NRTI and dolutegravir, which is an integrase inhibitor, and it is a preferred agent in patients who are supposed to undergo kidney transplant. So was already on appropriate therapy, and I didn't need to do any change to his therapy. And this was actually, I mentioned patient, this was a donor who was on tenofovir, lamivudine. She was also on similar kind of therapy, 2 NRTIs and 1 integrase inhibitor. So what we did, like how I went about it, in many places, I may have no justification to offer, a theoretical justification, but this is how we did. I took help of our friends from the transplant group, also did some reading, and then I had some of my own intuitions of doing the things. So rituximab 200 mg was used 2 weeks prior, which is our general protocol for all ABO incompatible patients. And triple immunosuppression was started a week prior, and without any clear guideline or so, I used at the half dose which I would otherwise use. This fellow was about 50 kg. So MMF was used at 500 BD, prednisolone, which otherwise we would start at 40, was started at 20 mg, tacrolimus at 1 mg BD. And with the potential of interaction with ART, although the patient was not receiving protease inhibitor, I did pre-transplant tacro testing also, and the titer was about 7 nanogram. Another issue was, obviously, luckily, the patient baseline titer was 1:32, and many programs accept at that particular titer. In my own personal practice, we accept patient at 1:8 IgG titer. But I didn't want to subject him to plasmapheresis. That was the issue. And of course, I did not want to use the adsorption columns, which are too expensive for this particular titer. So just as a proof of concept, incidentally, we have just now discussed case of TMA, where plasma infusion alone can be used because it can cause hemodilution. And I've just followed this particular intuition or previous reading just to do a plasma infusion. Anyhow, his baseline titer was good, so the risk was limited. So it was kind of calculated risk which I took. And I infused about 8 FFPs, B positive, like donor-specific blood group FFPs per day for 5 days. Patient weight was 52 kg, roughly his plasma volume would be about 2 liters, and FFP volume which I was infusing was about 1200 ml. So if you go mathematically, so I think his plasma volume was getting from 2 liter to 3 liter, and maybe he was getting 1/3 dilution in this way. To my own surprise, and maybe surprise for all those who are listening to this, because I'm really not aware that anybody has reported or presented something like this, like using plasma infusion alone as a treatment for achieving acceptable titers. This particular patient dropped to 1:4 IgG and 1:1 IgM about 2 days before kidney transplant. I didn't use any antibody induction, neither basiliximab or ATG, because I was too scared to use that. And no changes were made to ART composition nor to the doses. So, sorry. Then what happened? Luckily, a patient had completely uneventful clinical course during hospitalization, behaved like any other kidney transplant. I repeated, we generally don't repeat anti-blood group titers in post-transplant period unless there is allograft dysfunction. But for this particular patient, I repeated it about 5 days later, and his titer was 1:8. And compared to any other patient, I did more repeated testing of tacro, and we are getting stable tacro level. He was discharged at the creatinine of 1.21. His nadir creatinine during his hospital stay was 1.12. He has good urine output. His last follow-up was a few days back, and his creatinine is 1.18. He had no infections, and his viral load still is undetectable. And I'm doing monthly viral load and CD4 count for this particular patient. And last CD4 count is 312. So that's all. Donor has no issues. And because apparently this is first case, unique case, this got very nationwide media coverage, including nearly all editions of Times of India. So to conclude, HIV positive donor to HIV positive recipient, live donor kidney transplant is possible. Maybe can be managed as other cases. And primarily, I feel because we have now good ART, like this patient, he is surviving out of HIV for now 15 years and no detectable viral load. Of course, we have to adhere to available guidelines when we take these patients as a donor or recipient. Plasma infusion alone for reduction in blood group antibody titers may be possible. I just saw a comment, somebody mentioning that it can increase the risk of infection. Of course, it is possible. It didn't happen in this particular patient, apparently. And this is just something which I have done. I cannot, as I said, I cannot justify all I did completely, but this is what I did, and it has been a successful and good experience. It may not work for all patients, or even if they are not non-HIV or any other case. I really don't know whether plasma infusion alone can work, but it is our common practice to like at least in the last few sessions of plasmapheresis to infuse patient with donor specific FFP. I don't know how many other centers do it, and it works well. That is my own observation. So that's all I have to tell. I will be happy to get any valuable information and inputs, and we'll be happy to answer any questions. Thank you.
Thank you, Dr. Sachin. First of all, congratulations for making this to happen, like HIV positive donor and HIV positive recipient in ABO incompatible transplant.
HLA incompatible.
HLA incompatible. So, but you don't have a DSA, no? You don't have a DSA.
I know. I mentioned DSA was negative. I did.
Negative.
Yeah.
Mismatched and ABO incompatible transplant. Thank you for the congratulations.
So we generally do this DSA before, like at the time of rituximab, before rituximab infusion, because if you are doing DSA by flow cytometry method, then it may give false positive DSA later on. Yes. Subsequently, we do only flow cross match or CDC cross match. So I don't do DSA within 72 hours or something because it may confuse. That is my opinion. Yeah. So first of all, congrats, and you got a good 2 points actually. It is like plasma infusion in reducing the titers
getting away, and not using the induction therapy before transplant. And let me ask the panelist. So he has tried a new way of reducing the titers. What's a scientific way, and whether it can be adopted? Please give your inputs, respected panelist.
Yeah, it may stimulate discussion. I think definitely all the people who are listening. And obviously, I was playing on a safe pitch. So patient already had low titers. I just wanted to try something like this instead of doing a plasmapheresis. Yeah.
Dr. Raja, your sir, your comment.
I don't know, Raja, please go ahead. Okay.
Thank you, Dr. Soni, for this amazing case. I think it's wonderfully done, and you need not be so apologetic when you defend regarding plasma infusion. There is a scientific background, so you've done it right. I would say that, if you give a donor plasma, even our the blood transfusion physicians say the same thing. Like, when you give the donor plasma, it will get down the antibodies at least by 1 or 2, especially very high titers. It will get it down. So I think there is a scientific basis to all what you have done. So, and I would still not call it an HLA incompatible. We can say HLA mismatch and leave it over there. Usually incompatible with the antibodies. So, and I think these days it's all integrase based therapy only. That has really revolutionized treating these patients. Otherwise, we had a lot of problems with using abacavir or ritonavir in these set of patients. I think the national policy itself has changed towards dolutegravir, which makes a management of HIV and kidney transplant a little easier. So these are my comments, and it's fantastic job.
Yes, sir.
Just fantastic case where you have gone to levels where I would probably not think of going, but then beautifully done, and the outcomes have, of course, been very good. So it has happened good for the patient. One particular concern which I had was about the safety of a living donor who is having HIV infection. Because in this recipient also, we really don't know the cause of kidney disease. And I have a feeling, maybe it is a referral bias. We do get a small number of, the numbers are low, but then there are a small number of HIV positive patients who come with CKD for no obvious reason. And a good number of them we are unable to biopsy. So the one concern I had was whether that is a risk we need to consider when we are considering HIV positive living donor. When the patient is, when it is a diseased donor, which will mostly be the situation in other countries, especially the Western countries, this will not be a concern. But when we are actually considering a person with HIV and is on treatment and has a long life, because they now survive quite well. I'm not sure whether you looked at that data where they do have a higher incidence of CKD compared to HIV negative people. There's one concern with regard to living a donor with HIV I would have. The second question I had, which I don't have an answer, I'm sure Sachin would have checked that. Suppose the donor has a different variant of the virus. There are different variants. So what is the risk involved? Can the recipient get a different variant of the virus from the donor? And can that result in progression of HIV? In this patient also, we are seeing that the CD4 count actually came down almost by about half. It was around 500 something pre-transplant and 200 something. So is there a concern? I'm asking a question because I don't know, but there is some thought which came to my mind about the different variant from the donor can have an impact on the.
Should I answer now? So two issues you raised was living donor. So before taking her, I checked the guidelines. So I mentioned that the guidelines which I have mentioned, they are about living donor only. They are not about any cadaver or like any HIV positive donor. They are specifically living donor, and for them, kidney biopsy is must, which we did. Now, if you look into the overall history of this particular patient, this donor is 15 years post retroviral disease. And if kidney biopsy is normal now, of course, like you cannot preclude, but as the guidelines suggest and as per available limited experience, so there is not much experience, of course, and maybe over the period of time, I will even look at this, how it goes. Another interesting question which you had was about variant. So yes, it has been mentioned that if there are two different variants, it should not go ahead. But now you look into the logic of this particular, this patient, both of them had HIV-1. But along with that, you look at the logic. So this is a donor, is a spouse of the patient. And the way this donor may have got retroviral disease is from the patient itself. So it is unlikely that they are harboring two different. Of course, theoretically, it is possible that somebody will get retroviral from another source or another origin or through blood transfusion or any other way, needle prick or whatever. But likely explanation, the way this donor may have received HIV is from the patient itself. So probably we are not looking at two different variants. So that's what I mentioned to my colleagues. See, this is India. She received a retrovirus from her husband, and she is giving her kidney to the husband. So that's a paradox, maybe.
Yeah. The other, thank you for the clarification. My thought primarily for clarification of the donor part only. I didn't understand that you had done a biopsy, even though you showed the criteria. I probably missed that. You know, when you mentioned that biopsy was done on the donor. So that's a good thing. If the biopsy is clean, then likely that the patient. But I missed that part. The only other point I wanted to ask you was about the induction part. Normally, I believe if it is an ABO incompatible, is it your practice to give induction or you will avoid it? Or if the patient is not ABO incompatible and not having HIV or any other risk factors, but there is a HLM mismatch, 6/6, like it typically happens.
So in either of the situation, be it ABO incompatible or HLA mismatch, I would use induction immunosuppression, and my personal preference is to thymoglobulin. That is the practice which I have. But as I said, like I had no experience of doing such kind of transplant. I was scared more than transplant rejection. I was scared of the opportunistic infection for this particular patient. And whatever I read, I have read that lymphocyte depleting agent should be used with caution. There are some case reports, like there is a case report from Chennai itself, where HIV positive donor to HIV positive recipient was done many years back, but it was not ABO incompatible. It was ABO blood group match transplant. There is one case of ABO incompatible kidney transplant, but it was not from HIV positive donor, like HIV positive recipient, donor non-HIV positive, but it was ABO incompatible. That is from Dr. Bharat Shah. And both these articles, I read that these agents should be used with caution, and maybe lack of confidence or whatever you say. I was scared to use lymphocyte depleting, and probably, like you also pointed out, that his CD4 count has dropped. Probably if I had used induction immunosuppression agent, it would have dropped further. In the hindsight, I feel it was a good decision.
Okay, nice to know your thought process, Sachin. As usual, brilliant thought process. Thank you for the case as well as the explanations. Thank you.
So I have to, sorry, I have to leave the meeting. Actually, before accepting this invitation, I said, sorry, we have a Doctor's Day program. If all the questions are over, I will like to leave this meeting.
Okay. Okay, Sachin, let me have a discussion with the panelists. And if you are very much, thank you for joining us. So just 5 minutes, we'll be winding up the session actually. Dr. Raja, want to ask something? Actually.
Yeah, it was not asking, I just wanted to make a comment. So probably on Sachin Soni's side only. So one is regarding the variants of HIV. So, these patients, even while they are on therapy, if the viral load is positive, they can develop variants, even if they are acquired at the same time from the same source. But this patient had a negative viral load for a long time. It's not only 6 months, but they had it for a very long time. So I think that part would become redundant. That part of the discussion would become a little redundant. The second thing is about the CD4 cells dropping down. So it's a common thing that happens in post-transplant. If you give a lot of corticosteroids, which probably the patients did receive, as a part of induction therapy in transplant, he would have received methylprednisolone, and also the patient received rituximab. So they also cause lymphopenia. So the lymphopenia is probably related to the corticosteroids and rituximab rather than because of HIV, part. Would be my
Leave alone this case, actually, there are some variations of HIV treatment. Somebody is receiving a protease inhibitors. In such scenario, how do you titrate your TAC level before transplant? Is there any maneuvers?
I'm not very sure. See, we have patients are written where we have seen patients with attack level of 130, patients developing heart blocks and because of hyperkalemia and then revived. So I think now it's all the dolutegravir, dolutegravir, tenofovir, lamivudine-based therapy in most of the NATO guidelines. So that is what I learned. So I don't think it should be an issue as of now. So we are fairly stable at this point of time.
If somebody is on protease inhibitor, actually, when you come to when they come to us, so it is justified to change into like integrase inhibitors.
Yeah, I think now integrase inhibitors is a part of our NACO therapy itself, first line therapy. So I think they themselves, recommend this. So I'm not very sure. We need to ask a HIV expert on this. But yes, we do ask. We do not go with the protease inhibitors. We do recommend that they be on integrase inhibitors. Like
I heard one talk from Dr. P.S. Soundarajan sir, who did a HIV transplant some 10 years back when he was a resident.
okay.
And at that time, protease inhibitors were in vogue actually. So whenever he told us to start the immunosuppression, like 2 to 3 weeks before transplant, and titrate the TAC level along with your protease, so that to maintain the optimal TAC level before transplant. Actually, the immunosuppression should be started 1 month or 3 weeks before transplant, just like ABO incompatible, and to titrate the TAC level based upon their protease has to be continued, and TAC level will be titrated before transplant to that adequate level. That what was he presented at the time actually. So another one important thing is
regarding that part, I think it's not safe is what the literature says, as far as I understand. Even if you titrate it well before, so if it is feasible, my understanding is that we should change the ART into integrase-based regimen, because if they remain on protease inhibitor, even if you have titrated well in advance, post-transplant, it again the levels are going to be unpredictable and the rates of rejections are going to be high. So that's my understanding, and I think it makes sense to change the ART rather than try this. That's my understanding.
I think in current day that's not an issue at all, because we are not going towards them. Like it's a to gravir-based therapy.
So, do you advise induction therapy like this? What type of induction agent you prefer for this kind of patients? Whether besiliximab or ATG, which would be the ideal for this kind of patients?
I don't know. I'm very sure. Sorry, the stage.
Yeah.
Go ahead.
No, if you are asking me, Rajan, if you ask me, if I do a ABN compatible HIV positive patient like this, I would rather use besiliximab rather than using thymoglobulin. And I doubt I will do without induction. I will definitely not use thymoglobulin, but I think I will use besiliximab.
I guess I would differ a little bit, like, because if you carefully see, the space for besiliximab is contracting. There is no strong evidence to suggest that it offers the punch for the buck. That's one thing. Yeah, we don't use, but people do use besiliximab. But I think the space for it is contracting, and the emerging evidence suggests that it doesn't impact the medium term, short term, or the long term outcomes. So I think you can just go ahead. The patient, it does not mean the patient did not receive an induction agent. The patient did receive an induction agent in the form of rituximab, and that's probably done the job because you're doing a transplant at the peak level of rituximab, when the B cells are totally depleted. So I would see it that way. You could just proceed with transplant. Because if the patient does, otherwise the DSA is negative, cross-match is negative. So it's only the ABO part. ATG is not going to help in the ABO part. So I think you could directly proceed with transplant. It's a reasonably bet to just go ahead that way.
Sorry, Sorry, this is Dr. Pani.
Yeah.
I think rituximab as an induction agent in the context of transplantation, I mean, are slightly...
ABO.
Oh, in the context of ABO. But you're not targeting the T cells here, which are also important in this situation, especially in the context of 6x6 mismatch. So I think just using rituximab alone, even in the context of transplantation, I mean, I don't think it will be a useful induction agent to prevent the T cells from attacking the kidney. So I think if you want to use an induction, like not in the context of ABO incompatible, it has to be either basiliximab or ATG. And my preference probably would be to go for basiliximab. I agree with what you're saying. The space is decreasing, and there is no significant sort of differences in the outcomes. But that probably makes me feel a little bit safer.
Yeah, it's probably more. It gives us a peaceful sleep and sort of best apology also that way.
True. We tried, but
you go by the best. If you go by the evidence, no induction versus basiliximab, there's no difference. ATG, yes, 6x6 mismatch. We would certainly prefer ATG in a non-HIV and this kind of a setting. But yes,
correct.
Totally different is here.
Yeah.
One interesting question is, do plasma infusion this patient with the donor blood group, does it promote hemolysis? There's a small risk of hemolysis in the recipient when you infuse a large amount of plasma containing the donor blood group.
Practically, yes, I guess. But we haven't seen any that way. But
yeah,
it's been very minimal. So you'll have to do a lot of them. You'll have to do 300, 400, and then to really, say it scientifically. But I've not seen. But yes, theoretically, you will run a risk of hemolysis.
What is your experience on HIV transplant in your center, PGI?
See, we don't do live, so it's more of a cadaver program. So we do it in cadaver. Most of these HIV positive patients that we have done have received cadaver transplant. So there it is not an issue. They have been on HIV treatment for a very long time. They are on 2 years or 3 years. Their viral load is undetectable, and then they undergo a transplant, and they are on a dolutegravir based treatment only. So we have not had any issues, no rejections. They're all doing fine with creatinine, with an acceptable serum creatinine. I wouldn't say normal, because I think 2 of them had an expanded criteria donor, so they're doing at the creatinine 1.51.
So interesting, the dolutegravir has a preponderance for releasing the creatinine because it reduces secretion of creatinine from the cells. So how do you differentiate this from the any graft dysfunction, anything?
We'll have to accept little bit of a decline in creatinine because of dolutegravir, and then you're serially following up this patient.
Yeah.
That's the way I would say.
What is your prophylaxis actually? Do you give up septan prophylaxis for lifelong at 6 months? What are the prophylaxis? Do they receive the same prophylaxis as non-HIV recipients?
Yes, we do the same thing. What we do is we give the standard valganciclovir for 3 months and cotrimoxazole for 6 months. And after that, we stop if the CD4 is more than 200. If it is less, obviously, we continue the cotrimoxazole prophylaxis.
Okay.
Dr. Raja, for this patient,
Yeah.
Sorry, you're saying something.
Please go ahead.
No. For these patients receiving this cadaveric transplants, HIV positive patients, which is technically considered to be a high risk, immunological high risk. So you're not inducing them. You're just going with methylprednisolone.
So we are going with methylprednisolone alone. So
okay.
Luckily, most of our patients were all donor-specific antibody negative. The virtual cross-match is negative. So we don't do a physical cross-match these days. So we only do a virtual cross-match. So we proceeded that way. So that's how it is. So it's not uncommon that even with mismatches, we don't give induction therapy because of the financial issues that we face with many of our patients. So
And yeah.
it's not an uncommon practice. I know there are limitations and these practices can be challenged.
Yeah. And in terms of the virtual cross match, how often are you doing your DSAs?
So it's an annual basis. If somebody is neat means no antibodies. We do it on an annual basis. And if somebody is having antibodies at the baseline, then we do it. We recommend between 3 to 6 months, depending on how deep the pockets are.
Okay. And you get updated in terms if they had any blood transfusions in between, or
so there's a checklist where we just check upon, like, every time, whether if there is any blood transfusion, any chronic viral infections like hepatitis C, which the patient and they receive treatment for that, then what we do is we consider them as a risk of sensitization and repeat the DSAs in them.
Oh, great. Okay.
Thank you, Rajan.
Maybe 6 to 8
Yes.
weeks after.
Dr. Srijit?
Yeah, so I would say, I find it slightly problematic of, getting transplant completely free of induction. Sorry to say that, Raja, but especially in disease donor transplant, as well as mismatched transplants, spousal transplants. We have actually looked at our data, not huge numbers. As well as when we look at HIV, if you look at the literature and what we see, the rejection rates are actually supposed to be higher compared to other transplants. So I'm not sure. I agree with you that the long-term outcome data is not as good as thymoglobulin, but in the context of HLA mismatch transplant, you expect the immunological problems to be more. And when you have HIV transplant, even if it is I would say, near relative donor, literature says that the rejection rates are more. So what I would expect, I can't speak. We have only one patient where patient was HIV, the recipient was not, the donor was not HIV positive, the spouse was negative. So I can't talk from my experience. But what we have learned over the years, we started doing transplants largely without induction. Then we started routinely giving for spousal donors and disease donors. Spousal donors, we routinely used basiliximab, and for disease donor, we routinely use thymoglobulin. That too at 3 milligram minimum dose. This thing we have looked at the projection rates in these three categories. Near relatives, we have never been using induction unless they have a higher immunological risk based on DSA or flow cytometry. We have tweaked our immunological workup in last 3 years, where our use of inductions have gone up, primarily because of the data we found in our own patients. So I'm saying this also because I think we have a large number of trainees who are listening to us. And it may, I'm not sure whether we'll be giving whether we are giving a correct message if we say that induction is not really warranted. I understand that viewpoint, but then I think that is a very, something which we need to carefully look at. I would say it is far from certain that in a high immunological risk, when you expect higher rejection rates, you have HLA mismatch, you have disease donor, not using induction as a default option is the right decision when we look at the long, because most of the instances when we have done without induction, unfortunately, we don't have outcome data. Centers, I know most of the government centers, even us, have been doing living donor transplant without induction. But the outcome data are not there for us to compare. So I will not be very strongly advocating doing transplants without, in the context of disease donor, in the context of HLA complete mismatch, and you have HIV positive recipient where the rejections are all supposed to be high. I'll be very, very skeptical about advocating that. Okay, an individual patient, considering individual parameters, you may say, okay, fine, let me not use induction, but as a policy, I have my reservations.
Yeah, I agree on the points that you make, Dr. Srijit. My comments would be largely, it's not the question of, in the using induction or not also. It's also the kind of induction. I would say that if you are going to use basiliximab, I think it may be as good as not using it. But yes, if you look at the viral load, so if the viral load is negative and the patient is on regular antiviral therapy, there is a fair chance that even if you use ATG as an induction therapy in these patients, the viral load is not going to go up. And yes, the ATG effect would wane off after over 3 to 12 months, depending upon the dose that we use. So my comment would be largely, regarding the induction therapy, like if basiliximab may not do really good, I presume like many of the patients who take up for a HIV transplant, you are using basiliximab as an induction therapy.
We have only one patient, Raja, so I can't give you our experience. So,
Okay.
I'm telling based on the literature, not from our experience.
Okay.
It's another valid point that learners and new nephrology trainees are also here. So we have somewhat a good debate on whether to use an induction agent for these HIV positive patients. And you leave to you. And further data are needed, a long-term outcome and the data are required to confirm, to conclude whether to use or not. So that is an interesting session and very academically very interesting session. And it was a very fruitful to have all these questions and answers. And I hope the listeners would be having some inputs regarding the HIV-related transplants. And Dr. Vel Arvind, your comments?
Nothing, Raj, and I just listening and learning, and all two topics are new to me, and I learned a few points today.
I think we have answered all the questions, and one question is about the CME prophylaxis. I think it's around the same 100 days or 90 days, no? Dr. Raja, is there any change in that one?
Yeah, you can continue to follow the same thing that you have been following.
So we had a very two interesting sessions. That is a rare sessions, and we had a good fruitful discussions. I'd like to thank the speakers who have devoted the time in preparing the slides and came here to present in spite of this busy doctor's day. And thanks to the panelists, Dr. Raja Ramachandran, Dr. Srijit, for patiently hearing and answering all the questions and involving in the fruitful discussions. And also the participants, delegates who had come forward and to ask questions to make us clear about what is happening. And I must thank our media support like MQ team for providing us this platform to run this show. And with this, we can conclude this program. Our next program will be on next month, first Saturday. It will be fixed at month first Saturday. And we look forward to hear from you. Thank you for being with us and enlighten us regarding this renal transplant. Thank you very much, dear members.
Thank you. Bye.
Good night. Bye. Bye, sir.
Thank you, sir. Good night, sir.
Thank you. Thank you.
Thank you, Raj. Good night.
Thank you. Good night.